Before I share my presentation, I just wanted to tell a few things that IRCF is focusing a lot on the compression-only life support. And once you do this wonderful CCLS course, you have already learned COLS program. And the point is, you are going to be ambassador, you are going to train your people, your friends, your family members, your coordinators, your staff members, everyone for compression-only life support, so that the program goes across the country and is in great benefit of the community. But three things you need to emphasize on that. First is you need to create a willingness or a desire among the people, so that in a strange environment, in a wedding function or in a gym or in a mall or somewhere, or they are traveling, if person is trained, he is willing to help someone else. Second point is you must have the courage. Now we need a courage to resuscitate. Now he's not a medical person. He's in a strange environment with the unknown people. You must create the awareness, the willingness, and next is the courage, so that he knows he is an esteemed trained person. He can do some benefit, some difference to the victim. And third is the skills. You need to part them so well, so that if I am there or you are in that place and they have to resuscitate, they do a good job so that we are benefited. So this is what I wanted to emphasize for the course. Second point I want to raise before I start my presentation is, which is the only one diagnostic sign which will tell there is a cardiac arrest? Only one, carotid pulse, which you have learned well. Carotid pulse is the only one which will tell us that there is a cardiac arrest. And even if it is outside the hospital, within the hospital in a non-critical areas, or even the critical areas like ICUs, coronary care units, operation theaters, procedure rooms, anywhere, this is the only way. So this is, you need to learn well. And I'm sure the learned faculties have asked you to check carotid pulse when you did your BCLS course. But I'm trying to reinforce to check carotid pulse in many different necks, different neck with different architectural variations like short neck, no neck, thick neck. Somebody has a mandible touching the shoulders. So all these cases, it may be very difficult to check carotid pulse. So make a habit of palpating normal carotid pulse in any of your patients, friends, family members, time and again. That will give a practice to you. And when you've done such 50 different necks of different gender and different size of the neck, and the victim, when there is no carotid pulse, within the time frame of 5 to 10 seconds, you can tell there is no carotid pulse. For that, you need a courage and confidence. And second point is the quality of compression you learn in last BCLS, which you are going to practice today also on the Code Blue and in the practical session, where we reinforce and emphasize a lot for the quality of compression. Because if that is half-hearted or inadequate, your whole purpose, even if the person survives, is depicted. He doesn't survive with neurological good outcome. So quality of compression is the one you please master and do virtual exercise for the rate, for the depth, everything, even with the cup of coffee, sitting in the room, sitting on Sunday, sitting in the canteen, anytime with the friends, keep practicing the virtual 120 compressions and bug up the quality of compressions, which you have already learned. So these two things I wanted to emphasize before I share my presentation. Now, can I share my presentation? Is my screen visible?
Yes, sir.
Is my screen visible?
Yeah, very much, very much.
Okay.
Yes,
is it changing slide?
Yeah.
Yeah, okay, good. Thank you so much. Now, these two topics, which I prepondered mine on the stroke, and acute coronary syndrome. These two topics are, stroke and ACS are the common causes of cardiac arrest, particularly elderly and middle-aged people. And these two has been covered in the Comprehensive Cardiopulmonary Life Support course giving an overview, because there is a lot of importance, because when you are resuscitation or you are in emergency room or in anywhere in place, you receive such patient of either stroke or ACS, you must know the core link of this core, because they are the common cause of cardiac arrest. But we want to act before the cardiac arrest takes place. So they are reversible causes of cardiac arrest. And ultimately, your aim is to give them a good quality life without neurological deficit. So this is the purpose. I'm going to talk on a stroke, and Dr. Paul is going to talk next to me on the acute coronary syndrome. So now, there's a scope of learning for all CCLS provider. The salient feature of the stroke, it can happen outside the hospital, but within the hospital also. Most of the time it happens at home or outside the hospital during sleep, and we lose the chance. But whenever you get a chance, you must understand what is the core link for this. The core link is like cardiac arrest, immediate recognition. If it is outside, rapid transport to the place where it can be taken care, quick diagnosis and management. Now the time frame here is again very, very important. So the objective of this lecture would be to give the overview of stroke. What is stroke? What are the early signs and symptoms? The pre-hospital assessment and care, and in-hospital assessment and care. So basically, what is stroke? It's an acute neurological impairment following interruption in blood supply to the neurological tissues, particularly brain we are concerned. So now, the stroke could be either ischemic or hemorrhagic. In clinical practice, about 80-85% of the strokes are ischemic only, but less number of the people we get with the hemorrhagic stroke also, where again the surgical intervention may be necessary. So it is very important that you differentiate this ischemic stroke and hemorrhagic stroke. So these are two basic types of strokes. Now suddenly you find a weakness, or somebody complains of weakness or numbness on one side of the body, maybe face, arm, leg, anywhere. These are the common symptoms which we have observed, and I have myself witnessed in one of my friend's father in a party, where he suddenly said that I have weakness in my limb, and in 5 minutes his speech was slurred. So this is the time you need to recognize that he's developing a stroke. So sudden weakness or numbness on any side of the body, face, arm or leg. If he's dizzy, sudden confusion, loss of coordination, sudden speaking or understanding disability. You think he's confused, he did not answer you properly. Trouble seeing or loss of vision in any of the eyes or both eyes maybe. Severe headache or without any known cause. Now you must understand, a normal person who is elderly person, 75, 80, 85, and he has a severe headache, you be careful, he is the one who may be developing stroke, and that may be the only symptom he has that time. So these are the ones which you need to recognize quickly and understand the value of each symptom. About the pre-hospital assessment and care, you must understand the core link and the time frame. The outcome is always better if the time interval between onset of symptoms and arrival to hospital is short. So if it is outside the hospital and you get a call, as a friend you get a call that this is happening. So what is your action plan? Somebody says the symptoms. My father is developing this. My grandma is developing this. And you start action plan. So most important for the pre-hospital care is support of ABC. Is the primary triage and primary ABC. You have to understand the airway breathing, circulation and oxygenation. So rapid pre-hospital stroke assessment. There are various schemes like Cincinnati pre-hospital stroke scale. We are not going in detail of all this. And every hospital and every pre-hospital care system has their different system. But most of the people use this CPSS. Establish the time when the patient was normal. If somebody give you a call, that what time happened? Oh, he started at 8 o'clock. You write down the 8. Because now that time is very important for you to decide how quickly you want to get the imaging done. Transport as fast as possible to the hospital. Check blood glucose, because when you are teaching compression, when we are teaching resuscitation, we do not tell immediately glucose, but these are the cases where we need to check blood glucose immediately. Sharing information to the hospital before arrival. So the receiving hospital must have the information. This symptom started at 7 o'clock. Right now it is this. In half an hour, this is the progress. Now, most important is transport to the hospital where CT scanner is available or MRI facility is available. Now, there's no point in going into a medical nursing home when there are signs and symptoms of stroke, and they will have to shift them. So shifting takes a lot of precious time. And that's why the triage and support during transport is also equally important. If it deteriorates, you may have to be ventilated, and anything can happen during transport. So these are all continuous communication should have from the emergency room and department to the ambulance people. Now, I give an example. If some hospital is only 2 kilometers away, but when you call, say, sir, our CT scanner is out of order, then you take to a place which is maybe 6 kilometers away, but it must reach to the place where there is a CT scanner and MRI facility available. This is very, very important. Very rarely it happens within the hospital, but sometimes admitted patients with some other comorbid conditions, they may get it. So here things are very easy. When we assume your hospital has a scanner imaging facility available with you. So ABC of vital parameters important, oxygenation, IV access, check blood glucose, coagulation profile, CBC, everything, and quick neurological assessment. Normally we do AVPU. Like AVPU means alert, responding to verbal command, to painful stimulus, and non-responding. But here within the hospital, you can shift to the critical care unit or neurology unit and get a proper Glasgow Coma scale also and document. And also document the neurological deficits which are observed. We have the loss of tone in the limbs, face, eyes, eye movements, and everything, and pupil diameters. So this you need to quickly document, because that will help to check the progression of the disease later on in next 1 hour. Get the CT scan or MRI done. Now that time, get the history, look for the other comorbid conditions and medications patient is taking. That may be very important, anticoagulants or something is going on. Then you need to document this for further management. Activate the stroke team. Now, most of the multi-speciality hospitals have a very good stroke teams, and they have their own protocols and guidelines. But more or less, everywhere in the world, they are same, and they depend on the infrastructure available in that particular hospital. So you must follow the guidelines. So activate the stroke team, they will take over the patient from you. And get the 12-lead ECG, because many times the cardiac condition which has been overlooked or missed before this time, it could be the cause of the stroke. So CT scan is one of the most important diagnostic tool. You must get a non-contrast CT scan within frame of few hours, at least within 3 hours. If you have that stroke has happened outside, it may take some time to reach to the hospital. So you need to identify mainly whether it is hemorrhagic or not. If it is not hemorrhagic, then it could be ischemic. So this is what we need to identify, because that's where sometimes surgery is involved and the management also is changing. So look for hemorrhage. If there is no hemorrhage, look for other structural abnormalities, coning, midline shift, that will suggest you the intracranial pressure and how the life-threatening condition it is. I remember at 4 o'clock, we opened one and decompressed a huge hemorrhage in a 35-year-old lady. Just 3 days after the pregnancy, she got an hemorrhagic stroke. And at 3:30, she complained, and at 4:30, she was in the operation theater. Massive hemorrhage with coning, and when we put the tube in, heart rate was 32. And they just opened in decompression, she survived. So it's a resuscitation surgery, and which you have to be very lucky to be in that setup. Otherwise, this patient usually succumb. So this is what you need to identify immediately in CT scan. Do not waste time in CT scan. It has to be done in a short frame of time. Now in the CT scan, you find an hemorrhage. If it is a hemorrhage or no hemorrhage, you have found out. So if it is hemorrhage, you need to quickly involve a neurologist or a neurosurgeon. There may be a surgical indication for decompression, and that patient has to go to the OR immediately. So that later on, if it survives without much neurological damage. If there is no hemorrhage, then the neurologist will decide and may consider fibrinolytic therapy with the protocols they have in there and the the medicines they use, whatever, it depends on them. But this is the time when you are a resuscitator and you have identified these problems, you have got the CT scan done in emergency room, your role will be to convince and counsel the family members of the patient, because it is very important that first of all, the CT scan and MRI is to be done within 3 hours of the symptoms. Otherwise, you lose the golden time. And second point is that may need a fibrinolytic therapy, which own carries the risk. There may need a surgery where neurosurgeon is involved. So sometimes I have myself come across, they take, sir, can we take somebody's opinion? Now, this is the time they start doubting you. As they start doubting that hospital because they have come in the emergency, they start doubting the neurosurgeons you are involved. So now you need to convince and counsel them that I understand. In your place, I would also like to take a second opinion, but you don't have much time. If I take a second opinion, you may lose your important time. You may not survive. Your key family member may not survive, may survive with a neurological damage, which may not recover at all. So I suggest, we have done the best job. We have resuscitated you. We have brought the life in him, but needs a surgery or needs a fibrinolytic therapy by the neurophysicians. So this is what you need to convince them. Now, a little bit about the fibrinolytic therapy. There are contraindications. So you don't jump to it, but let neurologists decide, and you may support the family members and him whether this is indicated, but we cannot do it. So we are taking risk by not doing it. Particularly the cases like head injury, prior stroke, hypertension, bleeding diastasis, subarachnoid hemorrhage, history of previous intracranial hemorrhage, hypoglycemia. You need to correct it before you do decide your strategy. Recent MI may have received so many medications, heparin, clopidogrel, so many things. Recent GI bleed, you don't want him to bleed again. And pregnancy and major surgery taken place in recent past. So these are the relative and contraindications and limitations, and you have to balance it, and you have to decide with the help of the neurophysician which exactly you want to do, whether you want to do the fibrinolytic therapy or not, because it carries the complications like, again, intracranial hemorrhage, which was not there, other bleeding complications like GI bleed or something, angioedema, transient hypotension, and all are, some are mild, some are serious complications, which we need to put them forward. But you have to explain and counsel that unless we do this, it's not going to work well. So what my emphasis is very adequate aggressive resuscitation, identifying by the help of symptoms, signs, and scanner imaging, and involving the neurophysicians quickly or neurosurgeons quickly. And most important role, once you have resuscitated, they will put trust on you and counsel them for the further management by the advanced technique. Nowadays, a lot of endovascular therapy is also going on, like intra-arterial recombinant tissue plasminogen activator. So they do the endovascular surgeries, they do the endarterectomies, they put the stents, and many of these things are done within emergency, within a short time frame. So this depends on the facility, cath lab, and other things you have in your institution. But these things are very possible these days. By that time, you must continue the general care, like support of the airway, oxygenation, ventilation, intravascular volume maintenance, control of the blood pressure. If the blood pressure shoots up, systolic over 185 or diastolic 110 over, you need to put them on some vasodilator or intravenous medications, maybe beta blocker or something. But do not try to bring it very low so that the perfusion pressure goes down. So it's a cutoff limit where you need to be controlling. And that's your not job. You just resuscitate, you hand over to the neurology unit, and they will take over this. Blood glucose control has to be there, because many times it started with the hypoglycemia and he ended up in the stroke. Anticonvulsants. If they get seizures, please give the anticonvulsants. If they don't get the seizures, please do not give. There's no prophylactic anticonvulsant drugs to be given at this stage. And monitor the blood pressure well, monitor the StCO2 and everything. There is a stroke algorithm designed by every multi-specialty hospital who take care of stroke patients, who have a good neurology unit, who have all the imaging facilities. And normally there is now a stroke department. There's a designated neurophysician, designated doctors, nurses, and ICU designed for stroke management. And this stroke protocol are almost same with all multi-specialty hospitals. So whichever hospital you join, or you're sending your patients or family members or somebody, you must understand this and trust them. They will do the job for you. Thank you so much. It was just an overview of the stroke management, and I'll stop sharing my presentation. Faculties. Before I share my presentation, I want to tell two things. One is this, the curriculum of our course of Ccls, which is at par with any international guidelines, but has a little age over as pertaining to our requirement in our country, with our community and our customs and everything. So, and their resources. So this is I would say, international class course. Second point is, this is targeted for every doctor. It is not targeted for people working in ICU or operation theater or procedure room or in critical areas. So whatever you find, sometimes the simple medicine, simple things, very limited stuff. So the course is targeted to teach the best resuscitation protocols to the smallest clinic or an hospital in the remote areas with the inferior or inadequate infrastructure. So you can find you don't need very expensive things, number one. And number two is, most important is, and I am trying to reinforce what you learned, was the vigilance, identifying the unstable patient, stable patient, identifying the reversible cause of cardiac arrest, and then strategic thinking within time frames. Now, you had a good lecture on ECG. You saw the rhythms, you saw the practical sessions. So when you see a particular rhythm and patient is unstable, then you identify whether he needs an use of gazettes or medical management, or if he's a stable patient or unstable patient, is a bradyarrhythmia or tachyarrhythmia. So like that, strategic thinking, and probably the megacode time or the team approach session now onwards, after these lectures, you will learn more, you will interact with the speakers, and I am sure you will be benefited. The aim of the course is to teach you everything which you have already learned. If I have asked you to write an essay in 3 hours, you can write an essay on resuscitation. But in 15 seconds, if I tell you to identify the rhythm and give you some feedback about the patient, it may be very difficult for you to give your decision in that 30 seconds. So this is what the aim of this course is. Thank you so much. Now I'll share my presentation. Okay, visible? Is the presentation visible?
Yes, sir.
Okay, good. Thank you so much. When I say ROAC, means restoration of spontaneous circulation and post-resuscitation care is the topic, after you have done an excellent resuscitation as per the guidelines in the protocol. So that is what this object is. Now, this has been added now even in the international guidelines. What I want to emphasize and why I was trying to reinforce was the high quality CPR and time-based management of stable, unstable patient was this. We are responsible in which quality we give the patient after resuscitation to the specialist department. Eventually, we all know this, even after the best resuscitation, there is very high mortality and morbidity. There is cardiovascular instability, which needs support for maybe hours or days, or sometimes even procedural management also. Many of them end up in multi-organ failure, and most of them who do not recover well or not resuscitate well or did not get this best service may end up with neurological sequelae or brain damage, which will persist forever. And that is what the aim is. These days, neurological evaluation is considered one of the best marker of outcome of resuscitation, and is part of the assessment even in the post-resuscitation care also. So this is very important. That is what I'm trying to convince, that when you teach course, you teach the quality so well and time management so that by chance that person revives, survives of this episode, and he gets the chance to go to the hospital, he recovers from and recovers without neurological damage. That is our main goal. So this is what happens. So now for that, what you need to do is very high performance resuscitation with whatever you have learned today. See, action required is assessment of reversible cause of cardiac arrest during resuscitation and at the end of the resuscitation, and from the list, hit the target you learned in the lecture. Therefore, you studied in Rakesh lecture and probably has been covered today also on the skill sessions, where no cause is left out, where there is a reversible cause of cardiac arrest. So in that resuscitation time, when you are performing, your performance is high class, one has to evaluate, get the history, get the information from family members or somebody accompanying, get the history of the medications, and try to find out the cause. And that's how it will help us to give a better patient to the subsequent agencies like critical care or neurologist or cardiologist. They are going to take the patient from emergency room. Second action required is high performance cardiac arrest care, which includes restoration of blood pressure and establishment of ventilation. These two aspects we have to be very, very vigilant, and properly we should be doing it when you hand over the patient who has restored the circulation. So that includes optimization of ventilation and oxygenation, hemodynamic support, coronary intervention or reperfusion if it is necessary, advised by the specialist. Targeted temperature management, I'll discuss a little bit more elaborately how there's some we are skeptical about this, but that I will teach you, and the advanced critical care. So these are the things necessary immediately once you have restored the circulation and done a very good resuscitation. So the optimization of ventilation and oxygen, the patient could be unconscious or unresponsive. He may need an advanced airway. Now, you learned today that airway management starts with the manual maneuvers, the adjuncts, the supraglottic device, and endotracheal tube. If you can ventilate one person with bag valve mask, you don't use the adjuncts. If you can do with adjuncts and bag valve mask, you don't use supraglottic airway. Endotracheal tube is the last priority, because while the compression is going on, while the CPR is going on, resuscitation is going on, and that time hindrance in the activity of compression can further affect the patient. So there should be uninterrupted compression, and that's why endotracheal intubation is the last priority. But most of these patients ultimately will end up in endotracheal intubation. So once the circulation is established, you have to have a definitive airway, and best is the oral endotracheal tube. And you need to decide the method and mechanical ventilation support also. Now, capnography is now at this stage is a very, very important monitoring tool, and it detects the correct placement of the ET tube. It correlates with the cardiac output, and your aim should be to have end-tidal carbon dioxide between 35 to 45. That is ideal. Avoid excessive ventilation, because excessive ventilation and generating a lot of thoracic peak pressure can affect the venous return, can affect the cardiac output. So be careful, do not overinflate. Very minimal 6 or 5 ml per kilogram of ideal predicted body weight ventilation is adequate at this stage. And that will maintain the ETSO2 at 45-40. Rate also we control. You don't need 20 to 12, 14, 16. When you're just resuscitated, patient is to be shifted to the specialized unit. A rate of 10 is adequate. But there should not be hypoxia. So avoid hypoxia initially by giving 100% oxygen. But subsequently, once saturation is achieved, and if you could get blood gas done, it is achieved, you start lowering down FiO2, oxygen concentration, as low as possible up to 40. And your aim at this stage with the normal blood hemodynamic stable patient with normal blood pressure is to have SaO2 94 to 95 and not more. Don't aim for 100% SaO2. The reason being, if you give more oxygen at this stage for longer time, there are high chances of atelectasis, and many of them end up with atelectasis and hypoxic collapse, and then subsequently infection and pneumonia post-resuscitation in a couple of days. This we have learned well during COVID time ventilation. even at home with oxygenation, we were suggesting that don't keep SO2 100%. Try to bring it down to 9. So that much oxygen also only you should give. Ventilating with a lot of 100% oxygen definitely attracts atelectasis. The hemodynamic support. Target systolic pressure at least 90, but you don't have to bring it to 150, 160. And mean blood pressure of 65 millimeter of mercury. Proper IV access is necessary. You may have the central venous access, which we have not talked in the course anytime, and we don't recommend also. But now you can think about central venous access. You should load normal saline or regular some fluid, crystalloid, 1 to 2 liters at this stage, and then start monitoring this patient. Many of them who has had a cardiac event and you have recovered will need a pharmacological support with norepinephrine, dopamine, epinephrine infusions. Now this is time they need infusions, and the simple medicines are adequate to maintain the hemodynamics and shifting them to cardiology unit. And many of them will need any invasive procedures also, like balloon pump or cardiac procedures, PCI, or so many things, or in neurology, endarterectomy or something also can be suggested for this purpose. Now the time comes that you have identified the reversible cause, you're done in high performance resuscitation, and you need to refer them in a stable state to the unit. It could be cardiology, neurology, advanced critical care, or it can be even trauma unit. Now, coronary intervention, once you have finished your resuscitation, always ask for a 12-lead ECG in emergency room or the place where you have resuscitated only once the circulation is established, and then transfer them to cardiology. They can do aggressive STEMI, they can do coronary perfusion with percutaneous coronary intervention, anything, everything can be done immediately after the circulation has been established, and it's the hands of the cardiologist. Now, targeted temperature management is something very useful and strongly been recommended by even international guidelines. If patient is unresponsive and not following verbal commands to protect brain and other organs, this can be considered. So consider therapeutic hypothermia with aim between 32 to 36 degrees Celsius for 24 hours. This is a standard recommendation, but you can pull it up to 72 hours. And other procedures also can be done with coronary intervention, like PCI or anything, even while TTM is there. Only thing, the word of caution I want to give you at this stage is to maintain 32-34 degree in our infrastructure without any specialized cooling devices. Simply giving normal saline that came out from refrigerator can be dangerous, can go down, and can create a lot of cardiac problems. So we do not recommend this TTM in an infrastructure which cannot monitor temperature very well, the core temperature with the, if you have a ECMO, you can do that. If you have a bypass, you can do that. But otherwise, it is very difficult to control temperature up to 32. So don't aim for 32. But if patient, because of say brainstem injury or maybe pontine hemorrhage or something, hyperpyrexia is there, then you need to control it down to 36, 35 by tepid sponging on the surface and strictly monitor the core temperature. So this is a caution I want to give you in our infrastructure. If you cannot manage well, please do not do that. Now monitoring is very simple. We have to monitor the physiology, try to bring it to the normal physiological parameters with ET02, saturation, central venous pressure, arterial blood pressure, urine output, arterial blood gas, and core temperature. And most important is the serial neurological evaluation is absolutely mandatory. That is what actually we are aiming for after resuscitation. So once you have done a very high performance resuscitation, you are sure what you have done is correct, and you are trying to give the same status what the neurological status was before, whatever the cause of the cardiac arrest was. And subsequently, they will monitor at fixed hours with Glasgow coma scales and other parameters to determine the prognosis of neurological sequelae. So if I summarize quickly, you have done a very aggressive, high performance CPR with our guidelines. Now the time has come that you have given the individual victim with a good shape to the specialist. They have to do aggressive post-cardiac care management to prevent secondary injuries like pneumonitis and hemodynamic instability and neurological damage and everything, of which most important is aim to prevent brain and other organ damage. Particularly brain is important because if you give a life and send and semi-comatose or vegetative patient to the relatives, they are in dilemma whether to take home or not, and they survive with good nursing care at home for sometimes 6 months, 1 year and longer. That is, we have seen even in the years. So your aim is not to give such life. So for that, I urge and I reinforce again that learn the resuscitation part so well, because this depends more on the resuscitation as well as on the aggressive post-cardiac care management, and then transfer them to the advanced critical care. So this is what I wanted to convey briefly about the post-resuscitation care. We can have the questions. Dr. Binil?
Sir, 1 second.
Any questions from the audience? Any doubts, any points to be clarified? Just wait a moment. We'll see.
Yeah, no problem. And you have a mega code to be yet done. No? You have a skill session.
It's up to this.
Yeah. So that way, even in the closed group, you can have a good communication with everyone.
Yeah.
All the faculties.
Arriving for session. Any questions? Any doubts? Clarified? Oh, okay, sir. Thank you very much being with us.
Thank you very much, and wish you all the best. You've done a wonderful job, and I really appreciate the commendable efforts you people have done in this. And I was so happy to join you here. And certainly in the next few courses also, I'll be very happy to have you along with any help. Please let me know.
Okay, sir. Thank you for that.
Thank you so much.